Welcome, and thank you for standing by. Today's call is being recorded. If you have any objections, you may disconnect at this time. All participants are in a listen-only mode until the question and answer session of today's agenda. To ask a question at that time, you may press star one and clearly record your name for question introduction. I would now like to turn the call over to your host, Kimba Ford. Thank you.
Thank you. Hello, I am Kimber Ford of CDRH's Office of Communication and Education. I would like to welcome you to the FDA's 38th in a series of virtual town hall meetings to help answer technical questions about the development and validation of tests for SARS-CoV-2 during this public health emergency. Today, Timothy Stenzel, Director of the Office of In Vitro Diagnostics and Radiological Health and the Office of Product Evaluation and Quality, and Toby Lowe, Associate Director of the Office of In Vitro Diagnostics and Radiological Health, both from CDRH, will provide a brief update. Following opening remarks, we will open the line for your questions related to the development and validation of tests for SARS-CoV-2. Please remember that during this town hall, we are not able to respond to questions about specific submissions that might be under review. Thank you. I now turn the call over to Tim.
Hello, everyone, and welcome again to this continuing dialogue. It's a new year. I certainly hope that this is a much better year for us due to our combined efforts than the last year. So we look forward to assisting the development of new products that can play a key role in the pandemic. We were busy over the holidays. If you remained aware, we had a number of authorizations that happened, and that is carried into this week. One authorization that's a little bit unique is we did authorize the first antigen dipstick assay. So this is a simple strip that goes down into the test tube. It's authorized for point of care. There's been a lot of interest in very inexpensive tests, and this antigen test doesn't even have a plastic cartridge around it. So hopefully this adds to our arsenal. That is the Quidel QuickView SARS test. And joins the Abbott Binax Now as a very, very simple, non-instrumented antigen test. And it's just one example of the many awesome products that have been developed during the pandemic to meet our needs. It's I think a little bit unique in that it can really drive down the cost of a result, and because it's a rapid antigen test, it can be produced in high volumes, as you might expect, just like the Abbott Binax Now. And there are great other antigen tests. I just know that there's huge public interest in driving costs down, and so that's why I highlight that one. We, of course, want to continue to make clear what our priorities are. They're focused on those things that can have the greatest public health impact. So home tests, home collections, point of care tests, and super high volume central lab tests. All, primarily the diagnostic tests, but obviously we'll look at serology tests as well. So, these are our priorities, and if an application comes in and is complete and ticks one of these boxes, we will make it a priority to get you feedback as soon as possible and try to authorize these tests as soon as possible. We do continue to ask that the submissions are complete, that they're well written and clear, so that our folks can rapidly assess the submission. We also need line listing data submitted in a common spreadsheet. so that we can look at the data very quickly. We don't have to ask for this because we will ask for this, and it really is considered incomplete unless we have that line listing data, which should have the results plus any demographics of the candidate test plus the comparator test in enough detail. We also want to see your protocols for your clinical validation studies. Important, and a detailed one. It's important to know how you selected samples, how you collected samples, how you tested samples, how you did the comparator assay. These are all really important questions, and we really can't make our assessment without them. So it only slows us down if we don't have complete information about these things. I did want to also talk about another hot topic, and that is mutation. So we're all aware now of the UK variant mutation and the concern in the US, and we've seen a handful already confirmed. And then also the South African variant, which has some overlapping mutations, but also some clear differences between the South African variant and the UK variant. Both of these variants appear to be of higher infectivity due to the viral mutations, which enhance binding to the receptor. That's the theory, at least. I think there's some pretty good evidence for that. Some of them may also have increased amounts of virus, which increased amounts of virus and also greater binding to the receptor obviously can lead into greater infectivity. So it's important to understand the variants that are circulating. We do have an interest in sequencing-based tests that can provide a whole genome sequence. Of course, we've already authorized at least one such kit. That's the Illumina kit. It is authorized and has within it reagents to sequence the entire genome. And that's been a great step forward that we authorized quite a long time ago before we really knew how important the mutations would be. The other thing that the FDA has been doing is on a regular basis, of course, with all applicants, especially for the molecular assays, we've been asking them at least twice during the authorization process to check the known sequences of variants and explain any challenges with their primer and probe sets that may have with those variants that are in the database. In addition, the FDA has bioinformatics capability. We have the list of all EUA authorized primers and probes for molecular assays. And we have been interrogating the sequence databases to see if there are any mutations that could impact test performance. We have done this for the UK variant. We have done this for the South African variant. And we have done this prior to these variants for any variant that seen in the database that was at 5% of the sequences in the database or above. In all cases, we reach out to the test developers. We ask for their assessment of the impact of these mutations on the performance of the test. We do our own evaluation of what we anticipate might be a significant potential performance alteration, and work with the developers to assess the potential impact. As soon as all that work has reached a point where we feel like it's important to share any information with the community, we will. What I can talk about today, of course, is publicly known that the UK variant, there is at least one test out there that's been publicly mentioned. That's the Thermo Fisher TaqPath assay that has S-gene dropout. So with S-gene dropout, we have looked at a number of variants in the U.S. database and a number of sequences, and the majority to date do not have all of the UK variant mutations. What that means exactly, we're not sure yet, but only a subset right now in the U.S. have of the S-gene dropout by Thermo Fisher have that. We believe that around 5% of the Thermo Fisher positives have an S-gene dropout. But again, as I said, we think the great majority of those to date have not carried the UK variant mutations. So for the time being, at least, sequence verification of S-gene dropout samples is something that we would recommend. Hopefully, you have access to sequencing. As I mentioned, there is an EUA authorized sequencing assay from Illumina that can fit this purpose. Also, you can reach out to your state and local public health labs, and they may or may not have sequence capability. Some of them do, and or they can guide you in what's the best process to assess it. If you're a public health lab, the CDC has asked that those isolates, those samples, be sent to the CDC for sequencing. And so follow the CDC procedures, and I would refer the public health labs to the CDC for any further questions on that. Obviously, there are assay design issues that could be impacted by mutations, particularly if an assay is a single gene target assay. And there are a number of single gene target assays that we have authorized. So it goes without saying that multi-gene assays are going to be less impacted by mutations as they continue to propagate in this pandemic, and will have an advantage over single gene target assays. Some technologies don't lend themselves well to multi-gene targets. We understand that completely. There is nothing wrong with a single gene assay. However, there is a little bit more pressing need to understand, how variants might impact performance with single gene assays. With the Thermo Fisher assay, it is a 3-gene target assay. And with S-gene target dropout, you can still detect positives by the other 2 targets. So we don't know as of now that there's any significant decrease in test performance of the Thermo Fisher assay. And for the moment, at least, it's a very helpful assay to identify potential S-gene dropouts that could be the UK variant as we try to assess whether spread is continuing within the U.S. of the UK variant. Moving on to antigen tests, obviously there are mutations in the targets for antigen tests as well. It's a bit more difficult to assess the impact on antigen tests because we can't just simply look up sequences and primers and probes and identify whether there could be an impact on antigen tests. So the CDC has graciously agreed, at least for the UK variant, which they are now culturing, to test the EUA authorized antigen tests at the CDC for their ability to detect the UK variant. So we will be reaching out to all of the EUA authorized antigen tests and asking them to send their kits. I think we need to be looking at 75 to 100 tests worth to send to the CDC because they do multiple levels and multiple replicates, even for just a single variant, such as the UK variant. So stay tuned. If you're EUA authorized antigen test, we will be reaching out to you with more information shortly. And finally, I did want to mention serology tests. Obviously, they can be impacted as well. And we will need to await the availability of immune serum or plasma from certain variant patients in order to assess the impact on serology. We have put requests out already for such samples, obviously, and thankfully at the moment there aren't that many in the U.S. for UK variant and the South African variant, but if they do become more prevalent, we expect to be able to access immune plasma or serum to assess performance of serology tests. And again, antigen and serology tests are a little bit more difficult beasts to handle when it comes to assessing their performance with variants, but we'll do our best here given the limitations of biology and science. I don't believe I have any other preliminary remarks, so let's go ahead and open this up to questions, and we look forward to that. Thank you.
If you'd like to ask a question at this time, you may press star 1 and record your name clearly. Our first question will come from Wendy Strongen. Your line is now open.
I had a question about what the template says for point of care studies, and it says that in addition to studies with 30 positive and 30 negative samples, there should be a study with 5 to 6 untrained users with 3 positive and 3 negative samples showing that they can perform the test just following the test instructions. My understanding is that those 3 positive and negative samples could be contrived swab samples. Is that correct?
Toby, do you know the answer to that about contrived? I know we probably prefer pressure frozen samples for that.
Yeah, I'd have to look at the template to be sure.
Yeah, I don't believe
I would ask that you send that question into our templates email address box, and we'll get you a fast turnaround on that.
I actually did send it
as flexible as possible to get more and more point of care tests authorized.
I actually did send that in already, and I got an email back saying that was beyond the scope of things that could be sent in for questions. But I will send it in again.
Ask that Dr. Stenzel and Toby Lowe get copied. Resend it in. I apologize.
Okay, thank you very much.
Mm-hmm.
Our next question will come from Ishaka Merrily. Your line is now open. Ishaka, please check your mute button. Again, please check your mute button. Okay, our next question will come from Christine Chun. Your line is now open.
For reporting purposes, what CT cutoff would be appropriate, and would it correlate with infectivity?
Can you explain your question a little bit more? Are you developing a molecular assay, or are you using a molecular assay as a comparator?
Using a molecular assay as a comparator for a rapid antigen test.
Okay. So what we ask is that you use the EUA authorized comparator test as it's developed, and that you report all results to us in a line listing. We are not using a CT cutoff or some sort of infectivity cutoff because, in fact, CT is very widely. For rapid antigen tests, we have seen CTs as high as 40 in the first 5 days of symptoms. And exactly why that happens, don't know yet, but we very clearly see a healthy or an unhealthy number of high CT results in the first 5 to 7 days of symptoms. And so we feel it's important that when someone has symptoms that we know the true performance of the antigen test. Now, we do recommend that direct antigen tests set their inclusion and exclusion criteria for their clinical study appropriately. We don't really expect that antigen tests are going to perform well after 5 to 7 days, depending on the test. Some tests do a little bit better than that, but the bulk of tests have been authorized in the 5 to 7 day symptomatic period. And we want to understand of symptomatic people who are confirmed positive to be SARS positive, what is the detection rate of those people with antigen tests?
Mm-hmm. Okay. And for clinical validation as a screening test, what is the recommended minimum number of positive and negative PCR cases?
So if you're going for a screening claim, an asymptomatic screening claim, and if you're doing it as your first and only study, then I believe you need 30 positives. If you are adding it, there are a couple of different options for you, whether you're adding it to an already authorized test or you're doing it in line with seeking your first EUA authorization. We have a minimum, I believe, depending on the pathway, of 10 positive asymptomatic patients pre-market or pre-authorization. If you're doing this with an antigen test, I would recommend that you perform a study that will maximize our understanding of your true performance in the asymptomatic population that makes sense. So as I said, antigen tests are at their peak performance in the first 5 to 7 days of symptoms. Virus peaks, virus levels and shedding peak in that typically peak in that window, and it may be earlier on in that window than later on in that window. We really know that after a week of somebody shedding virus, that antigen test performance will fall. And whereas a molecular test may be a good molecular test may be, quite positive out to 14 days, but well beyond perhaps the days of symptomology if someone were be having symptoms. So the sort of the best study design that will give you the best chances for showing excellent performance with an antigen test will be to link up with one of the serial testing programs. There's many on college campuses, maybe in workplaces, maybe in schools, and screening at a minimum, say, of every week with a molecular comparator that can be used for the comparator of record for your asymptomatic study. And you can enrich, so you can wait until somebody identifies positives with that screening program. You can contact the individuals and see if they're willing to test with your test. And then we'll also want you to throw in an equal number at least of negatives to keep everybody honest. So that's probably the best way to enrich for asymptomatics at levels of virus level that we expect to see the antigen tests perform well in. I'll pause there in case you have any questions about that study design.
Thank you for all of that information. I will take that back.
Okay, you're welcome. There will be a transcript of this that will be posted as soon as possible, usually by Monday following, for those who are interested. Thanks.
And as a reminder, if you'd like to ask a question, please press *1 and record your name clearly. Our next question will come from Corbin Venkat. Your line is now open.
Good afternoon. Thank you for taking a call. I just wanted to, I think Dr. Stenzel mentioned about the priority of different tests. Do you mind if you can just tell the priority once again? I probably have missed when you were talking.
Yeah, just briefly, point of care tests, home tests, and home collection. I'm primarily focused on diagnostic tests, so those would be molecular and antigen tests. But we will also make serology tests in these categories a priority. And then high-throughput central lab testing that can really help drive down turnaround times for test results. These are usually on automated platforms or automated systems. And those are the priorities.
Thank you. So as far as the serology, now that vaccination is getting implemented, what your office and the FDA thinks about the serology test in vaccinated individuals as of infection? Do you have any thought and guidance that you can share with us?
First of all, vaccines are reviewed by a different center. They are reviewed by CBER. And I would refer any questions you might have to them as well. The data needed to show that serology can be predictive in any way would be important for us to be able to review for any submission related to vaccines. There is no prohibition in any of the serology tests that we've authorized for use by clinicians to try to assess things. But we do urge caution because we have not authorized any serology tests for use with vaccines for any purpose, to either determine whether a vaccine is needed or determine if the vaccine has taken effect and provides any sort of immunity. In fact, we haven't even authorized a serology test around an immunity claim. We have authorized semi-quant serology tests and a neutralizing antibody serology test. Those perhaps could be more useful in assessing at least the question of immunity, not necessarily that anybody can use them right now to declare immunity. That would be something that I think would be a bit dangerous right now.
Yeah, my question is similar to what you were mentioning about the variants when you have, you were telling, you are going to look at the serology test, how in the variant, how they are performing. My question is the people who got immunized, in those people, how the serology tests will perform, and will it give a false positive, or I'm kind of asking in that context rather than looking at the immunity level.
Yeah, I think your question is, if somebody gets a vaccine, can you tell if they've developed antibodies to SARS using a serology
I'm not
test?
asking that.
So we have not authorized the test for that. To get authorized for that purpose to allow marketing would require, a potentially significant study, in conjunction with a vaccine study or trial. So we're open to developers who want to pursue this. So we would ask that you draft a clinical study plan and send it to us, and we would assess its ability to answer the question and allow an authorization. I do believe that these are going to be very significantly large studies. And, it's a bit dangerous for the FDA to say, oh, you've developed antibodies and to a vaccine, and now this is what it means, And so developing antibodies to a vaccine is potentially very similar to developing antibodies to the actual SARS infection. So, but if somebody a developer wants to pursue specific claims, we're open to looking at the study design. We would review this in conjunction, of course, with CBER.
And our next question will come from Teresa Hermiich. Your line is now open.
Yes, thank you so much for taking my question. My question is regarding the use of controls. Does FDA have any recommendations regarding the use of endogenous or exogenous controls for use in an antigen test?
In antigen tests, what kind of exogenous controls?
We are in the process of developing, so I just need a general guidance. If there is a guidance document or recommendations as to how we should be looking at controls for antigen tests.
It's obviously nice to have controls, especially endogenous control that could assess the quality of the sample. But it's not a requirement for EUA authorization. We will assess test performance without such. The only requirement regarding such controls or the only recommendation rather for controls has been with unobserved home collection samples, where we just have no idea if a patient has self-collected a sample well enough for performance in an assay that doesn't have an endogenous controls. We have updated authorizations for some developers after they had already launched with an endogenous control and assessed performance in their home tests, looking at literally thousands of data points. And have been able to back off on the requirement for endogenous controls in some cases. But for right now, for a new developer with the new sort of home collection, we would like to see that data.
Thank you. I have another question regarding the use of antigen tests for screening purposes, because the current antigen tests, they have intended use claim for a certain number of days post onset of symptoms. If we are planning to develop an antigen test for screening purpose, given the antigen tests are normally most effective for first week or 10 days post onset, how does FDA look at the clinical trial and also samples that are being collected? Do they have to, because this is for asymptomatic, what would be FDA guidance in that regard?
Yeah, one of the previous callers had that same question, and I went into in long detail on that. So I would recommend that I'm not going to repeat it here. I would recommend you look for our transcript that should come out on or about Monday next week. Of my remarks on this call. It does suggest a optimized study design that will give antigen tests the best possible situation to show excellent performance in asymptomatic patients.
Thank you.
Mm-hmm.
And as a reminder, I'd like to remind each caller to ask one question throughout today's Q&A. And if you'd like to ask questions, you may press star 1 and record your name clearly. Our next question will come from Wendy Stronging. Your line is now open.
Could you comment on what are acceptable enrichment strategies for an antigen, a rapid antigen test, and specifically, would screening everyone coming to a COVID testing center for the presence of symptoms to COVID be an acceptable enrichment strategy?
This is people with symptoms or people without symptoms that you're looking for?
No, we want to get positives. So people are presenting to a COVID testing center. Some of them have symptoms, some of them don't have symptoms. So in order to try to enrich to get positives, symptomatic positives, for not for an asymptomatic claim, we want to screen for people who have had symptoms in the last 8 days, or symptoms that started no more than 8 days ago.
And is this for an antigen test or for a molecular test?
A rapid antigen test.
Yeah. Well, we might be amenable to that. I would send in, a pre-EUA requesting input on that. I don't think it's a particularly good study design. I'll just be honest. I mean, the positivity rates out there are sky high. And, you don't have to run a lot of tests in a clinic that's seeing people with symptoms to get your minimum 30 positives. And yeah, you'll have, you'll have a number of negatives, but unfortunately, virus is running pretty hot out there right now. And that kind of enrichment, I don't believe is needed, and there are some challenges. We have expressed flexibility for enrichment around asymptomatic testing, just because to do this well for an antigen test, I believe it should be a population that is serially tested. That'll give the antigen test the best opportunity to show its excellent performance in the first 5 to 7 days of shedding of virus. But for those that have symptoms, it's just the virus is just hot out there. But if you really want to pursue that, send in a request for a study review in a pre-EUA, and we'll look at it. I just don't. I don't know what our team is going to say, and I wouldn't recommend it.
All right, thank you.
Our next question will come from Ishaka Mirali. Your line is now open. Again, if you called in from the line of Ishaka Mirali, your line is now open. If you press star 1 to ask a question, your line is open. Well, then as a reminder, if you'd like to ask a question, you may press star 1 to ask that question. Again, to ask a question, that would be star 1. One moment, please, to see if we gather additional questions. And I'm currently showing no additional questions at this time. There is a last-minute question. Would you all like to take that, or would you like me to turn that call back over?
Oh, no. We'll take it up. We'll give some period of time after we have a last question for someone else to dial in up until the closing time. We don't want to rush to close out the call. But yeah, we'll take it.
And I believe that question comes from Homer Creel. Your line is now open.
Yes, hello, Romain Prieur. Just a quick question around the mutation. UK, you mentioned CDC has agreed to perform, some testing there for existing EUA tests. And I wonder, would that be also available for developers that are in the process of developing an antigen test?
I think that there is the right timing to do that. It after the assay is locked down, there may eventually be live virus of the UK variant deposited in the BEI bank, and or irradiated or heme-activated virus. There also are pseudovirus constructs you can make to assess on your own, but I think we don't necessarily want to inundate the CDC at an early stage of development. We're hoping that none of the antigen tests are impacted, but it is important. And we'll get a good idea, I think, with the first tests we look at. Frequently, it's the N gene that's targeted by antigen tests. And that probably is a bit more conserved in some respects than the spike protein. Okay? But once you've locked it down and you're going to come in with a submission, I would reach out and check the status of this situation, because I think it's probably going to be beneficial for us to, at this moment, I would say it'd be beneficial for us to know what the reactivity is of a developed test that's being evaluated at the FDA for the UK variant. But we just want to time that correctly in your development process.
Thank you very much.
And our next question will come from Isha Verily. Your line is now open.
Hi, can you hear me? Hello?
Yes. Yes.
Okay. You said my name before. You just didn't pronounce it right, so I didn't realize it was me. Anyways, I thank you for having these town hall calls. They're really helpful. So we are developing a point-of-care over-the-counter test that is meant for work space, for work, for schools. It's a breath test. We submitted a pre-EUA in July, in the beginning of July, and we were appointed a reviewer. We still haven't received any feedback on our questions, and it's been quite a while now, and we really want to continue to performing our validation study. So is there any advice you could give on that? And just the end of that question is, would a validation study that's appropriate for the EUA could be appropriate for submitting for receiving a 510K clearance? Thank you.
So hang on the line a little bit. So if you reached out in July, I don't know that we would have had prepared recommendations to share with developers. Did you get any information back when you reached out that we had prepared? Because I know we now have prepared at least a subset of recommendations for breath test developers.
We have not received any recommendation for breath test developers, and we have tried to be in touch with our reviewer.
Okay. Well, I apologize for that. Send an email back to the templates email box and ask for Dr. Stenzel and Toby Lowe to be copied on the request, and we'll make sure that you get feedback relatively immediately with those recommendations, and I'll look into why your pre-EUA has not been responded to.
Thank you. I just to make it clear, should I send the pre-EUA together with that to the template email?
Yeah, you can copy that. You can copy that again. Advise the template email.
After and we rewrote it after you published the template in the end of July, so I could put both versions there.
Okay, yeah, that would be great. Make sure that your reviewer has both versions, but you can, again, send an email to the templates email box, put both versions on. I'll make sure that you get the feedback that we can immediately give for those that are seeking to understand what our recommendations are about breadth tests. And again, I will look into the pre-UA and either Toby or I will get back to you with an update on that. I think you asked another question and I lost it. Could you re-ask the other question you had related to this?
If we get green light to go ahead with our clinical validation study with the study design, would that be applicable for a 510K clearance as well?
Oh yeah. So let me just talk about the transition a little bit from EUA to 510Ks or de novos if you're the first one in. And this applies to anything SARS related, and even for like some categories like molecular, there'll be at the very minimum a single target SARS, a single virus assay, like SARS only category, and then there will be a panel category. Those each would be separate de novo submissions. Once a de novo is authorized within one of the categories, every follow-on assay will be a 510K submission. For those developers who want to know about what is required for what is recommended for the conversion, we are working on a guidance document that would be draft at first, but it may not go into enough details across the board for all EUA type products. And so I have asked our team to draft some information that we can share with developers. Primarily, it's going to be what is different about SARS from a standard, say, antigen in infectious disease, respiratory infectious disease, antigen, serology, and or molecular tests. So our feedback is going to be focused on what's different because we're just swamped with work and submissions, and so we want to focus on the things that are truly different about SARS and our responses. And then for the more commonly, factors for any of these categories of tests, we would urge you to look at our recent decision summaries for de novos and 510Ks, including any special controls for all the sort of commonly asked questions about a respiratory virus test. But we'll focus on the things that are different. The other thing is there is I do not perceive a need to rush to converting EUAs. We still have so many EUA applications to process, and we get so many new ones every week. It's really, an unprecedented volume and continued volume. And so our focus is really going to be primarily on getting EUAs authorized. And until the emergency ends, which I don't foresee this happening anytime soon, EUA submissions are going to be allowed, EUA tests are going to be allowed. And even if it were to end at some point, we're drafting guidance that will allow a very reasonable transition time point. Timeline, so that there will not be something that's we believe is unreasonable in as far as time goes to convert these. But I do understand that we are going to ask more for conversion, and it probably is wise for all developers to start thinking about those conversions and at least collecting the samples now when SARS is prevalent, to be able to do those conversion studies, if that's interesting and important to you, to convert at the point where it's important to convert. So hopefully that answers the question.
Thank you.
And our last question will come from Alexis Sauerbudge. Your line is now open.
Hi, thanks very much for taking my call. I had a question with regards to the CDC test and the current mutations. Do you have any indication or information that the CDC primers may be affected by any mutations that are circulating?
Yeah, I would, to be formally correct in my answer, I would need to check with the team. What I will say is that as soon as we have confirmed a potential impact on a test, whether it be molecular, antigen, or serology, we will endeavor to make that information public as soon as possible. So certainly the primers and probe sequences for the CDC assay are published, and people can look at mutations and see how they might affect those primers and probes. But I don't have anything to announce at the moment about any test other than the test I mentioned before, which was Thermo Fisher.
Great, thank you very much. I appreciate it.
Uh-huh.
And that was our last question. I would like to turn the call back over to Kimba Ford. Thank you.
Thank you. This is Kimba Ford. We appreciate your participation and thoughtful questions during today's town hall.